I'm joined today by Dr. Tom Hastings, a true accountable primary care physician in St. Louis, Missouri. In this episode of Tuning Healthcare, Tom and I will discuss workflow and how an accountable primary care physician changes their workflow. We'll also talk about the transition to value-based care and how you do that, and how in today's age, we have plenty of information, but we're common sense poor. Join Tom and I in his medical practice in St. Louis as we tune healthcare. Tom, thanks for having us in your practice.
Great to have you.
What excites me about being in your practice specifically, and then ultimately to have this conversation with you, is that you're at the epicenter of the transformation to value-based care. You are a primary care physician who's been practicing what I would call accountable primary care for many years. In fact, when I think about an accountable primary care physician, my image is Dr. Tom Hastings. But let's start at the beginning. Did you always intend to be a physician?
No, I didn't. I got excited when I was a senior in high school, and I took an anatomy physiology course, and that's when I fell in love with the whole thing. I was a C/B student, all through high school. Never really studied, never really did anything. And I didn't get really excited until I got into college and started really taking some deep dives into the pre-med stuff. And it came easily for me. I liked it a lot. Part of the reason why I do general is I like everything. And so it's fun to learn and continue to learn. It's been a great life. I've been highly professionally satisfied doing what I'm doing. So,
which is obviously an incredible statement from a primary care physician. Many primary care physicians you interact with feel burnt out, or they feel that they've been unsatisfied, they're not practicing at the top of their license.
Right.
But for you, it's been the opposite.
Exactly.
Why is that?
Well, I think there's a number of different reasons. I think a lot of it is workflow and trying to get the workflow right to be more efficient, make your office work better. Like we work at the top of our license, we have our MAs work at the top of their license. So we employ and delegate, frequently and often to make our lives better. And it also makes everybody's professional life much more satisfying. Everybody feels like they're contributing as a team. So it's a team-based care. I think before we called it team-based care. A lot more delegation, I think, here. And I think the patients like it because they're served better, the response time's better, and they like our office, and we like coming to work. And that's half the battle.
Right. That's great. So we've jumped straight into one of the things that I've noticed on visiting your practice over the years is that you just have a different workflow to many other practices I've been into, either as an executive at Lumeris or as a patient. And so tell us a little bit about your workflow. How does the day start? What is it that's so unique about the way you look at the patient, both from the beginning, the work you do before the patient ever walks in the door, all the way through to how you manage your day? We were chatting just before we went on air about your inbox, right? So take us through the Hastings workflow.
This is kind of exciting to talk about because, the Super Bowl's coming up, and Andy Reid is like this great coach for the Kansas City Chiefs for years. And it's all about game plan and planning. And so when I think of our morning huddle, I use that analogy frequently often. It's a game. It's a sports game. It's a game with a purpose, though, because the purpose is to provide better care and to have a better plan for your day. Often, days as a primary care physician is just full of the unexpected. And so if you can plan things better, then when the unexpected things pop up, at least you have a plan to handle those kinds of things. For instance, when we look at our huddle at the beginning of the day, and we try to involve all the office staff, but mostly it's just with myself and my MA, you look at each patient and what their needs are going to be, and you try to plan it out. Now, not always what you anticipate is what they came in for, and we recognize and understand that. But if they need things like immunizations or their diabetic metrics brought up to to date or screening, then we can plan that out. We can say patient A needs a colonoscopy. We need to get that scheduled so she can know that she already needs to do that. They need to be updated on their Pneumovax or their tetanus, so she knows that they already need to do that. And you do that frequently and often enough, then it also happens automatically. And it doesn't have to be me entering the order. They're reminding me, or they're entering the order themselves, which is always good to do.
Let's talk a little bit about the MA, right?
Yes.
Because what you have done extremely well, right, is how to maximize, let's actually broaden it not just to the MA, but what you've done extremely well is how to maximize the team, as you said, right? So you've got your medical assistant, right, who, let's talk about what
right.
they do, but then also your scheduler, like the whole office is
right.
part of the delivery of care, which enables you to sort of move up a level and practice at the top of your license.
What we tried to do, because, one of the unexpected things that we ran into in other offices that I was at is, somebody was out. And so when I started my own office in 2003, what we decided to do, I was in by myself at that time, and we had 3 different positions. We had somebody answering the phones, we had somebody rooming the patients, and somebody drawing blood. And so those are the 3 different roles in my 3 MAs, and they would rotate so that if one was ever out, the other could step in. And so now that we're a larger office, I'm with a partner now, we adopt that same kind of philosophy where I work with one MA for a month, Dr. Ganager works for another MA for a month. We have the blood draw and we have the phone answering. And so then we rotate those positions on a regular basis. So everybody knows everybody else's job. So anybody can step into anything at any time. So, and what it's done is it creates a tremendous work ethic in the office, because even when somebody's busy, say, can you room a patient for me? Because I'm busy, ordering an exercise stress test or whatever, they'll do that. And we use Cisco Jabber in the office because we're larger now. It used to be we just kind of holler and everybody pitch in, but now we're a little more electronic with that. And so, and everybody has it up on their screens and everybody has their computers in front of them as throughout your workday, so that we jabber each other, need help here, need help there, and everybody pitches in. At the end of the day, when we have a strong ethic, get here early, plan the day, get all the inboxes empty at the beginning of the day, and then work efficiently. If we need extra time, we take that out of the noon hour, but we try to very diligently end on time then, and then finish all our inboxes. Now, key in this kind of workflow is doing work in between when you see patients, so nothing accumulates in your inbox to an overwhelming degree. So we're always signing our papers as we go through. We always check our inboxes, either the paper inboxes, electronic inboxes, email if we can, but that sometimes will wait to the end of the day, of course. But in terms of the workflow of the things that need to get done, so that keeps the work going throughout the day, keeps everybody busy throughout the day, so that when we're done, we empty our inboxes and everybody gets out on time.
Do you round yourself in the hospital?
I do. And, the hospital rounding has gotten less and less over the years for whatever reason. I think we're doing more as an outpatient now. And the acuity level in the hospital is getting more and more as time has gone on. So acuity level is greater. Patients appreciate it when they see me, usually. They don't want to be there. But they appreciate, just looking in, even if it's, not in my field, if it's some other kind of thing. Now, I don't go to all hospitals. That's the other thing. I used to go to all hospitals, and of course you can't do that because of all the electronic systems are so different. But now I just go to one hospital. But in the others, we try to maintain good communication, and we try. Don't always make it, but we try to make sure at least we communicate with what's going on with the patient while they're in the hospital, to make sure we can kind of coordinate.
So you brought up the Super Bowl as obviously as someone originally from Kansas City. You're happy right now. Although by the time we air, we'll know whether you've whether you truly were happy or not. But so you truly are the quarterback of care for that
very much so.
Patient. So talk a little bit also about the relationship with the specialist. How does that because you demand different things and more communication from specialists than perhaps the typical primary care physician who's 100% in fee for service.
The key attributes there in terms of relationships with specialists, and just like they are with patients, is trust and integrity. I want to refer to specialists that I trust and are of high integrity, and they do what's appropriate for the patients at the time they need it. In getting everybody kind of on the same page in terms of what drives value is very important. And so a lot of times in medicine, we just kind of did a lot because we thought that was better. And, 35 years of practice has shown more is not always better. It's just not the case. So we always have to focus on what's best for the patient, especially in the elderly. What's best for them? What is the ultimate goal of care? And if it's helping them be more independent, then it's of value. If they're already not independent and they're suffering or in pain, then the goal needs to be more palliative in terms of providing them better support at the end of life. Often, 30 years ago, we just did things because we could, without a good view of whether it was really going to change the outcome. And so when we refer to specialists, it's just with the attitude and the spirit that we want to drive better value care for the patient.
Right. No, that's great. In fact, I was with the CFO of a health system today, and I was talking about that when I used to play soccer back in the day, it was how much running could you do, up and down, play as much. There was no high intensity training. There was very little about nutrition. There was very little about, it was just like, run as much as you can, play as much as you can, because then you'll be better because what we were actually talking in the context of our conversation was actually about Lumeris, right? And the value Lumeris brings to the health system today actually is these updated methods, right? That intellectual property. How do you engage a primary care physician and enable them to practice like right. Dr. Hastings, right? And so for those physicians that are starting off, you've been doing this for a while.
Yeah.
How'd you start? Where'd you start? What advice would you give to someone who recognizes that fee-for-service revenue is only going to decline?
Yeah.
But I've been living in this treadmill, and my infrastructure set up. Where do they start? How do they? And what are sort of the first couple of steps that you would recommend they do?
There's a couple of things that pop into my head right off, and of course we always have these tapes from our father that rattle around in our brains. But he was always big about education and education, education. And he was always big about common sense ain't so common. So when I think about education, it means that it's a never-ending process. You are always learning something new. And so just start by recognizing and acknowledging, antithetical to our medical educational system, where we try to develop high esteem, in our physicians. So when they come out of training, they think, I know everything and I'm ready to practice. No. Come out humbled and ready to learn. That's the biggest message I can think of, because it's all one great big learning process over and over again. The other thing is about common sense. It's focusing on the type of learning that will help make your life easier, improve value of care for your patients, and not just here in the office, but in their whole spectrum, in their whole life. Improve relationships with the people you work with, because I think that good relationships with the people you work with translates to better relationships with your patients. If you've got a good working relationship in your office, when you walk in to see the patient, you're already coming from a good mindset. Read every self-help book you can find. Read a lot about emotional intelligence. The one book I'm reading now is The Power of Vulnerability by Brené Brown. She's excellent. And so that's my next, big thing. But there's lots of very good self-help books. So I would focus not so much on the scientific, employ technology to its highest degree. Okay, we have more information now, but we're common sense poor. So you have to leverage the communication, leverage the information such that it's framed and presented in a way that is most helpful to the patient. You can quote statistics, but you can't quote what's of value for the person. So you have to continuously be focused on what's of value for the person, and be able to articulate that in a way that's consistent and open.
That's amazing. So, and great advice. Let's switch topics for a second, right? You're part of a broader group, ESSA Health, and ESSA had the foresight, right, many years ago to start a Medicare Advantage plan, Essence Healthcare, which is obviously now part of the Lumeris family of companies, and Lumeris runs Essence Healthcare. But take us a little bit back through the history. First of all, my first question would be like, how did you and your colleagues have the foresight that we needed to start a Medicare Advantage plan? I mean, this is so far before the Affordable Care Act. I mean, this is long before anyone was talking about accountable primary care or population health or all the jazz words that exist today. And it was to some degree, not too far after so many institutions had lost their shirts in running plans and felt burnt by it. And so take us a little bit back in time and talk us through the mindset, because I mean, looking back, it was the most amazing, the most amazing decision. I mean, you helped create perhaps the premier Medicare Advantage plan in the country, right? 4.5 or 5 stars for 10 years in a row. Medical loss ratio is great. I mean, it is the epitome of high quality, efficient delivery of healthcare with 5-star patient satisfaction. And but let's go back to what was the thought process?
Well, we weren't thinking about any of that. It was in business there's what they call the burning platform, and for us the burning platform at the time was healthcare was a mess, and we couldn't change. You can't change everything, but you can look at your piece and figure out how can we make this better. And so it started with a lot of like-minded primary care physicians that just wanted to, contract better, figure out how to work more efficiently, how to get value-based care into the picture. And I think of when we were first really trying to practice evidence-based medicines, Tom Dorr who was a key intellect in our group, who helped drive a lot of the things that we do today. He said, it's all about fidelity to the evidence. I'll never forget that. And so what we had to do is look at what we were doing and say, is this helping or is this hurting? Is this necessary or is it necessary? Is it of value or of no value? And Tom drove that for us. Tom Dorr was a powerful force and a powerful intellect to do the research. And this was before we had things like UpToDate, before we had things like, the Johns Hopkins, antibiotic guide and things like that. We were doing things like that. But Tom was doing the research. Other doctors too. I think of other doctors in our group. Stan Vrieselar really helped us with our electronic medical system. The next gen, when it came out of the box, wasn't so good, but we've done a lot of work with the templates and it's much, much improved now. So it's a team of people. I think of our leadership, all the people in our leadership today, and how we've evolved over the years. And so anyway, I have to take a little bit of a back seat to that, because while I was a driver here, and I was participated in leadership, but I have to really credit our leadership for that.
Yeah, I can't let you mention Tom without sharing. Obviously, for those that don't know, Tom unexpectedly passed away not too long ago, and enormous impact on my career at Lumeris as well. And when you say sort of fidelity to the evidence, when I think of Tom Dorr, I think of integrity, right?
Absolutely.
And that is, that in many ways, jives with what you said before about integrity and trust with the specialist, integrity and trust with the patient. Incredible influence in
more important. Well, integrity obviously very important, but his passion, his passion to be a person of integrity, his passion to be a religious person. It kind of pervaded many parts of his life, and so he was really passionate about making sure that we had systems, information, structure that would help promote better care, less costly care.
Roll the clock forward. Talk to us a little bit about how critical that collaborative payer is, right? Having Essence Healthcare as that collaborative payer, as opposed to, we don't have to name names, but in terms of sort of the experience you've had with other payers over the course of time.
Right. What we value is not an adversarial relationship, but a companion, a value-driven companion. Part of the problem with the way healthcare is structured, 1960s, 70s, 80s, today even, is that it's in a adversarial. One person's profit is another person's waste. And as long as that structure exists, then there's going to be continued antagonism, unless it can all be in alignment, where everybody is driven to drive less cost, higher quality, then it's going to be an issue. So a collaborative payer model structured so that everybody benefits from the value that it's created, and you try to identify value where it happens. And we were able early on to identify value in primary care and capture it, but you try to capture the value where the decisions are made. And so that's just what we try to do.
And as you think about managing populations, you obviously have a decent Medicare Advantage panel size. Talk to us a little bit about Medicare Advantage and sort of how critical is that as you think about managing populations,
right,
and the learnings that you've picked up from that, and how do you apply that to sort of the other populations that you manage?
We don't distinguish just simply because we're not smart enough. When you drive an efficient system, you drive it for the whole practice. You don't drive it for different segments of the practice. That'd be impossible to do, number one. But number two, it's freeing. It gives you, it's like lightening your load. It's like, okay, I can, if somebody needs an hour, I can spend that hour with them. If they don't need to be seen, I can treat them over the phone, and they're happy and I'm happy. We're just dipping our toe into telehealth visits. Many visits people don't really need to come to the office for. And so we're trying to identify those low value visits when people come in, they're on their meds, they're stable. It's good to maintain relationships, but you can maintain relationships in other ways. And so we're trying to leverage things. So in the traditional primary care office, it's all about RVUs and getting 30 people a day and staying until 7 o'clock at night to get all your work done. And you go home, you're tired, and it affects the rest of your life. So in a value-driven model where you're prepaid, and you can reorient the work so that it's much more efficient and everybody's happy.
I must admit that I don't think I've yet to meet a physician that hasn't told me their quality is excellent, that they practice excellent medicine, and I'm sure many do. But by definition, right, little over 50% of the population of physicians are below average.
Yeah.
Right. So talk to us a little about within ESSA. How do you, without, again, I don't want any names.
No. This is very important.
How do you maintain that quality among peers, particularly amongst both a population of doctors that are confident in their capabilities, generally speaking, and also, for the most part, when you're in the exam room, right, it's you and the patient, right? Mm-hmm. When I want to work with my colleagues, even if I say, hey, this is the way we should do it, doesn't mean we're going to do it that way. We have to influence each other. We have to get buy-in. We have to collaborate. So how do you maintain quality as you have done and improve quality across the health body of physicians?
Well, first of all, with great humility. Okay, and I'm going to go through a little bit of our quality improvement journey. I was with a group long ago that drove this. John Wasson had a thing. It was a site that patients would go to assess the practice, in his performance. And it was as good as CG Chaps and things like that. And it was How's Your Health was the name of it. And so it was Ideal Medical Practice and How's Your Health. And that's how it kind of got started. And, oh my gosh, we can work more efficiently. We don't need all this space. We can get by with a little bit less. But anyway, there's a lot of different attributes that I really enjoyed about the Ideal Medical Practice. And one of the things that was so good about that was when I came back to my group, okay, and on our quality improvement journey, if you will, it came that we were very, very closed. And this is where that power of vulnerability is so important, because we're all not as good as we think we are. And I remember first measuring, and I was like, oh, I'm good. Well, Dr. Gandiger came and joined me. He's a little better. I don't know. But it gets a little competition going too. And we would tease, because we post our quality improvement results on screens in the back. Now, that's important for a couple of reasons. Number one, it keeps our eye on the ball. It lets our staff know, hey, look, this is how we're being measured. Hey, you didn't get a hemoglobin A1C on that diabetic. Do you want one? Yeah, you bet. We do. And so, again, you have to come from a space of openness, humility, and vulnerability, and with the spirit that everybody just wants to be better. So it's taken a long time, but we've started taking we've become more and more transparent with offices and names. It used to be everybody was an A, B, C, D, but what was happening was people would look at themselves in comparison to others and say, well, how are they doing that? How are you doing that? So people start looking at the performance of others and start sharing best practices a little bit more openly. So it's trust. It's knowing we're all in this together. We all want to make sure that we're better, and transparency. And so, but to get to transparency, you got to have trust. You got to be vulnerable with one another. You got to be open with one another, and you got to be want to change.
And so that's the quality side of it. One of the things that always impresses me is that you have a handle on the cost side as well, and you're often engaging your patients, talk about the cost of care as well as the quality.
Patients are driving that more and more too.
Right.
And so, so we try to take the cost information into the exam room, and that's really important. So we have GoodRx for prescriptions, because everybody's worried about that. For where to go for different care, people want to know where to go for different care, and so we have a matrix we keep in the back. So different insurance will have different copays for inpatient, outpatient, so patients will know how much they have to pay. And then it's really an exercise that we do in our group frequently through the rearview mirror by looking at our performance quarter to quarter. So we're always looking at our performance and where the money goes, how it's spent, and then how to improve. How to be better with that. Where are our costs high? Where are our costs, where are our opportunities for improvement? So looking for opportunities to improve in your practice is a constant, ongoing thing. Years ago, it was driving towards generics. Now, as you look at all the price of generic drugs, it's getting the right generic, because all generics are not priced equally. And so patients really appreciate it, because, Social Security checks only go so far. And everything that I write or do is gouging their Social Security check or Medicare. And we just can't afford that. They can't afford that. Country can't afford that. You and I can't afford that. I'm cheap when it comes to my own prescriptions, and so I try to put myself in my patient's shoes. It's with great empathy and compassion that I try to always put myself in the patient's shoes. What did they want? What is it? And what is it that they really want? Because they might think they want something, but what they really want might be something completely different. So getting to that value is important.
Yeah. one of the things that I think is very interesting to people is not just, we spoke a little bit about how you start
Right.
as a
Yes.
value-based
Oh,
care,
yeah, right.
and
Way back.
then a little bit of the progression. So I remember coming here, must have been now about 8 years ago. I don't know if you remember this. Anish Chopra was the chief technology officer of the United States at the time.
I forgot about that.
And John Doerr wanted him to come see
come
see how a true, primary care
value-driven,
physician value-driven primary care physician had how he or she should practice. And so that's already now 7-8 years ago. So what have you done in the last 8 years that you would say that if he were to come back now, he would say, oh, these are 3 things that I do better than I did even back then. And even then you were, again, would have been my example of an accountable primary care physician. But what are like 3 things in the last sort of 7-8 years you think are much better than what they were?
Well, when he visited, the thing that stuck with me the most is, how do we scale this? That just hit me square between the eyes. I mean, I was like a deer in headlights. I don't know. You're the policy guy. How do you scale this? And but it got me thinking a lot about that, and I got our group thinking a lot about that. And so, number one is doing what I'm doing right now. Sharing what we do, making sure that we've started a new company within our group to try to help other groups perform better in value-based world. And so we're trying to share the methods more freely than we have in the past, so that others can learn from our experience, our mistakes and experiences. But the truth be told is, it's all about culture. It's all about culture. It's getting the right culture. So how do you share that? And it takes a long time to develop the right culture in it's still an ongoing process in our own group. It's just never stops.
Which is truly amazing, and I use it as an example all the time when, as you know, Lumeris is focused on enabling health systems to move to value-based care, and obviously we're working both with the employed physicians as well as the affiliated physicians. And I actually use the example of, without the name, but I use the example of that you just gave all the time, which is even in our highest performing groups that we've worked with for over a decade, there's always opportunity and remains opportunity to improve and get better. And it sounds like it should be obvious, because in every sphere of life we've always got areas to improve and get better. But it's amazing that both, even the highest performing physicians have that opportunity, as well as a group, there are always opportunities.
Well, there's a thing called Choosing Wisely. I'm on the Business Healthcare Coalition. This is the other thing I did. Actually, I got more active in the Business Healthcare Coalition. So when Anish Chopra says, how do we scale this? I said, well, I got to understand what the concerns are for employers and what they're doing to address their issues. So I was trying to make a better study of the payers in general, so that we have a better understanding and can partner better. Because we all want better care for our employees and our loved ones. They're a family, and so
absolutely.
So it's important.
So I always like to end with a couple of quick fire questions. Best piece of advice you've ever received?
Never stop learning.
Right, it's a great one. What's the first thing, or one of the first things you tell new patients your first time you're interacting with them?
I try to let them know everything about the office, and that it's all about education. The more they know about their disease process and what works and what doesn't to treat that, the better they'll comply. If I can make a good value proposition to them, this is the reason why they need to take their hypertensives, they'll take it. And if they don't, they won't. And I always try to, more and more, and this is an exercise that I fail at. Well, let's put it this way. I failed way too frequently before, is I didn't know what they valued. And so I'm trying really, really hard to listen much better now to figure out what they value, what they want, what are their goals for their care.
And finally, if there's one thing about healthcare you could change, what would that be?
If I could snap my finger, and be like Harry Potter, or, I say with patients, I'm in a Star Trek world, and if there's something I can't really do much about, I take my otoscope and I put it over them and I go, woo, like they do on Star Trek, make it all better. Okay, so there's certain things that I would just love to just snap and make better. If I could snap my finger, I would change the medical education system and the payment system all at the same time. I would change the culture of medical education in the country, and I would change how physicians are paid for their work. I would do that in a nanosecond.
Tom, thank you so much. I could actually sit and chat to you for hours. And what strikes me every time I have an opportunity to sit with you is I always learn something new. So thanks for inviting us into your office. And
thanks for coming.
Thanks for taking the time to chat to us today.
No, I appreciate it.
Thank you for joining us today. Don't forget to follow us on your favorite streamer, SoundCloud, Spotify, or Apple Podcasts. In addition, please rate us. And if you'd like more information about Lumeris, please go to lumeris.com. Join us next time on Tuning Healthcare.